Thank you for inviting me to talk today. I'm going to be speaking on Lewy body dementia, and I work as a clinical academic at the University of Southampton and at Southern Health NHS Foundation Trust, so just down the coast from you. I'm visiting Brighton next week actually for a conference, so I might bump into you by the seaside. So my first slide is just to confirm that I've got no commercial relationships to declare that are relevant for this talk. And over the next 15 minutes or so, bearing in mind that I'm the last speaker, so I will definitely keep to time, I'm going to plan to give you a very quick recap of the clinical presentation of Lewy body dementia and quickly run through some of the published research into particularly the prevalence and the prognosis of Lewy body dementia, and very much focus on the clinical research aspects of those that work. And I'll end by just touching on some emerging topics to keep an eye on in the next few years in this field, and hopefully have a couple of minutes for questions. So firstly, how is Lewy body dementia defined? Well, the only way to diagnose any neurodegenerative cause of dementia, in my opinion, so things like Alzheimer's disease or Lewy body dementia, is to examine the brain at post-mortem. So if we were to do that for someone with Lewy body dementia, what would we find? Well, we know that DLB is characterized by the presence of alpha-synuclein pathology in both the cortex and subcortical regions at postmortem. And these clump into intracellular inclusion bodies that primarily develop into Lewy bodies. And these Lewy bodies are found in the cortex, as I've said, in dementia with Lewy bodies, but also in subcortical regions. Now, it should be noted that Lewy bodies are also the core pathological feature of Parkinson's disease. And in Parkinson's disease, they're primarily found in the substantia nigra, an area that controls voluntary motor movement. But it's also interesting to see that also frequently present in the DLB brain is pathology that you'd more typically find in Alzheimer's disease, so amyloid plaques on the left and tau tangles on the right. So there is overlap in terms of neuropathology between Alzheimer's disease and dementia with Lewy bodies. Now, it's all well and good diagnosing DLB at post-mortem, but that's not particularly helpful for our patients. So how does DLB present in life? Well, it's characterized by a rather unique combination of clinical features. So firstly, fluctuations. Patients with DLB can present with fluctuations in attention or cognition, and that can present with excessive daytime sleepiness, drowsiness, episodes of staring into space or falling asleep at the drop of a hat. Another core feature are the motor symptoms of Parkinsonism. So people with DLB can typically present with rigidity or slowness of movement or bradykinesia rather than tremor. People with DLB can also present with REM sleep behavior disorder. So this is where people lose their normal muscle atonia during the rapid eye movement phases of sleep, and they can end up acting out their dreams. And for some reason, they tend to be often dreams of fighting or of some sort of conflict. And lastly, visual hallucinations are another core feature of DLB. So these are normally vivid hallucinations, typically of animals or people. You'd think that it would be a relatively easy diagnosis to make if you've got these four core features, but unfortunately, or fortunately from the patient's perspective, you don't normally see all of these core features at once, and you can often see them in other disorders. So, for example, Parkinsonism is obviously a key feature of Parkinson's disease. It also can be tricky to be clear about whether a feature is there or not. So how much fluctuation or how much sleepiness do you have to have in order to satisfy that core feature? And to complicate things even more, DLB is associated with a myriad of other clinical features as listed here. I've only listed a few here, but there are many more. And some of them overlap with medical or psychiatric disorders. So for example, depression, apathy, and anxiety can present in a functional disorder. Transient episodes of unresponsiveness can be mistaken for transient ischemic attacks or TIAs or absent seizures. So it can be very tricky to pin down this diagnosis. But thankfully, there are diagnostic criteria which have been agreed through international consensus. Now, these require at least 2 core features or 1 core feature and an indicative biomarker for a diagnosis of probable DLB. Now, you'll note that some of these, or all of these core features aren't present in everyone with DLB, particularly the Parkinsonian symptom. And now the most widely used biomarker is dopaminergic SPECT, which is also known as a DAT scan. And I think it's interesting to note that this isn't required for a diagnosis of DLB if the clinical picture is clear. So if you already have 2 or more core clinical features of DLB, then there's no real point in undertaking a DAT scan to confirm the diagnosis, particularly because there's a not insignificant number of false negatives with regards to the DAT scan. Now, the eagle-eyed among you will have noticed that during my talk, I seamlessly changed from talking about LBD or Lewy body dementia to dementia with Lewy bodies. So from LBD to DLB. So what is the difference? I agree that the terminology can be confusing, and I'll attempt to try and clarify this now. So LBD in the more broader sense, as an abbreviation for Lewy body diseases, describes any disease associated with the presence of Lewy bodies in the brain, and that can include Parkinson's disease dementia, or dementia with Lewy bodies. Now, we know that the majority of people with Parkinson's disease, and some studies state that up to 70% of people over 10 years will go on to get Parkinson's disease dementia, so dementia in established Parkinson's disease. And it's also noteworthy that not everyone with DLB has Parkinsonism, so you can have DLB and not have Parkinsonism, so it can be a bit of a confusing picture. Now, people with DLB and PDD can present very similarly. Their pathology is very similar in the brain, and the principles of management are also very similar. So they can be termed together as Lewy body dementia. Now, going back to DLB only, the DLB consensus criteria that I just mentioned on the previous slide that were published in 2017 still include this rather arbitrary 1-year rule. And that says that when the onset of dementia occurs at least 1 year after the onset of Parkinsonism, that's termed Parkinson's disease dementia. But when the onset of dementia precedes or occurs within 1 year of the onset of Parkinsonism, that's termed dementia with Lewy bodies. And we can debate how useful or not particularly useful that arbitrary split is. So how common is DLB? Well, the prevalence of DLB in post-mortem studies has been estimated to be as high as 15% of all cases of dementia. But clinically, we see nowhere near that amount. So the community prevalence is known to be lower than that figure. Now, this was an interesting study, I thought. It was published a few years ago, but showed the prevalence of DLB in routine memory clinic services, in old age psychiatry services, across 2 UK areas, so in the northeast and in East Anglia, and it measured the number of cases of DLB divided by the total number of cases coming through those services. And that actually split it by community mental health teams, so it was quite interesting to see the differences between teams. And that study showed that the prevalence of DLB was significantly higher in the northeast compared to East Anglia. Now, we could discuss whether there are any environmental factors or anything else that could explain that, but I think the most likely reason is that the northeast is home to Newcastle, which is the world centre for many dementia with Lewy bodies researchers, and you'll be hard pushed to go through training without knowing exactly how to pick up a case of DLB. So what was interesting, though, is that there was also within-region variation between community mental health teams that were very similar in other ways, but had differences in rates of diagnosis. So that implies that there were differences in diagnostic practice, and also implies that we're probably missing lots of cases of DLB. Now, there's interesting research evidence about the pathway to diagnosis of DLB. And the first line here is that it can take much longer to reach a final diagnosis. In fact, twice as long to get a diagnosis of DLB than a non-DLB dementia. And there's also evidence that people with DLB have more alternative prior diagnoses. So things like Alzheimer's disease or Parkinson's disease, they undergo more investigative scans, and they have more clinical contacts than people with non-DLB dementias. So there's clear evidence, and not just from this study, but from others, that the pathway to diagnosis of DLB is longer, more arduous, and more complex for people with DLB than for people with non-DLB dementias. And I think that's incredibly important to recognise as a healthcare service. Now, there's excellent work that's been developed by Newcastle University on this area in terms of improving the diagnosis rates of DLB. This is an extract from the Diamond Lewy toolkit, which is freely available online. I think you can just use a search, a Google or other search for Diamond Lewy, and come up with this assessment toolkit. They also have a management toolkit as well, and I think they have them for both, for DLB and for PDD. And it includes a list of validated questions that you can use, that anyone can use in Memory Clinic, to pick up some of these core symptoms of DLB. And I thoroughly recommend it if you don't use it already. It's brief, it's only a couple of slides long, it's easy to use, it's great for training, particularly for trainees. And the website has an excellent video on how to administer it and how to examine for Parkinsonism as well. So it's thoroughly recommended. But why do we need to get better at diagnosing DLB at an earlier stage? Well, we know that the prognosis is poorer in DLB. We know that people with DLB are hospitalized to acute hospitals more frequently. We know that they have a higher mortality rate. We know that they end up in care homes earlier. And we know that their carers suffer greater stress than people with Alzheimer's, carers of people with Alzheimer's disease. So it's imperative, I think, that we get better at diagnosing and picking this disease up earlier in order to allow for more tailored care planning. Now, clearly, the non-pharmacological strategies to manage dementia are hugely important, as it would be in any cause of dementia. Thinking about the pharmacological strategies that you can use in treating DLB, there's very good evidence now that cholinesterase inhibitors, including donepezil, well, especially donepezil and rivastigmine, have excellent evidence in improving cognition, attention, and neuropsychiatric symptoms, including hallucinations, and also reducing carer stress in DLB. And there's actually evidence that they work better in DLB than they do in Alzheimer's disease, with the theory that the cholinergic deficit in DLB is more prominent compared to Alzheimer's disease, so the drugs work better. Clearly, there's a caution that needs to be applied to antipsychotics due to the neuroleptic sensitivity that you get with DLB, but I recognise that they are sometimes necessary. And there are other medications to use for other symptoms. So clonazepam can be used, a low dose at night can be used for troublesome REM sleep behavior disorder. Levodopa can be used for motor symptoms of Parkinsonism. But I think it's clear if somebody does have Parkinsonism, that it needs to be alignment and closer working together with other services. So we're in Southampton setting up a regular MDT between the geriatricians, between the neurologists and the old age psychiatrists to discuss complex patients with complex issues in patients with Parkinson's disease and with DLB. Now, there are challenges in terms of the management of DLB. So as I've said earlier, there are multiple symptoms, and rather frustratingly, the treatment of some of those symptoms can worsen others. So giving a dopamine agonist for Parkinsonism can induce psychotic symptoms or worsen hallucinations, and vice versa. Treating hallucinations or delusions in DLB with antipsychotics can worsen Parkinsonism symptoms. So it can be a really difficult decision to make, but I think I'd recommend having that frank conversation with patients and carers to discuss what the priorities are when it comes to treatments. Now, I'd just like to end by briefly mentioning a few areas of research that I think are really exciting and things to watch out for over the next few years. There's lots of work going on in the field of biomarkers and Alzheimer's disease, and the same is happening in dementia with Lewy bodies and Parkinson's disease dementia, with a particular view, I think, in the next few years, if we can get a PET ligand for alpha-synuclein, similar to the ones for amyloid and tau in Alzheimer's disease, I think that would be a really good development. And I know that there's lots of work going on in that area at the moment. We in Southampton are leading some research that's being done across the UK, looking at the role of inflammation in dementia with Lewy bodies and Parkinson's disease dementia. So that's another really exciting area which could lead to new strategies for treatments. TopPat is a study that I just like to plug. It's a multi-centre UK trial testing ondansetron for the treatment of visual hallucinations in Parkinson's disease and in Lewy body dementia. And both Professor Tibet and myself are co-investigators on an NIHR health technology assessment grant testing memantine as an add-on treatment in Lewy body dementia. So it's very much a case of watch this space over the next few years, and hopefully we'll have some more treatments for these symptoms. That's the end of my talk. So thank you very much for listening.